Dr. Amitabha Saha, Director of Critical Care Medicines and Senior Consultant Internal Medicines, working for 35 years in this industry. And many of you probably I know personally. And today I got invitations from your side. I'm grateful for that. And the topic was requested for a Nipah virus, which is now is the talk of the town. And we need to understand that why Nipah virus and what is Nipah virus. So let's start today. So the objective of today's discussions will be on the review of the global and Indian epidemiology. We need to understand the transmissions and how can we exposed. That explains the pathogenesis and organ failure, how it affects the patients. And when the patient is getting infected, what would be the ICU management and the public health response. So in a very short, this is the Nipah virus, which is the family of Paramyxoviridae and genus the Henipape virus. It is basically an enveloped virus, and the most important is the negatively sensed RNA virus. And the case fatality when it is been infected, it is almost 40 to 75%. So this is a more close-up view of Nipah virus. As we know, you can see here that there is the RNA genome of NPM FGL, which is one of the component which we can diagnose of the Nipah virus, and this is the matrix and the envelope of Nipah virus, and this is the G glycoprotein. So these are the proteins that we can understand and we can actually check in the lab to understand that whether the patient is infected with the Nipah virus or not. So may I request everyone to get yourself mute because there is a background noise which is happening. And this is the global perspective that how the different part of the world is being infected through these Nipah viruses. One of the components that has been first diagnosed in the way back of 1998 to 1990 in Malaysia and Singapore. And there is also a Bangladesh which has been recurrent outbreak or annual outbreaks. But in India, we hardly have some data infections very regularly. But yes, there is an incidence in way back to 2001 and 2007, 2018, 19, 21, and 23. The continuous Nipah virus infections and epidemics happened in the state of Kerala. But in Bengal, we have only 3 incidences that is happening that way back to 2001, then 2007, and is now happening in 2026. And as we all know that the Nipah virus is very high mortality to the healthcare workers. So this is the West Bengal recent Nipah virus alert has been given by the Bengal of government, the health department, that trigger to understand or suspect the patients may suffer from the Nipah virus if the patient is having a suspected encephalitis and which must have traveled to the cluster of the area, and if there is any exposure history. So the first immediate action should be the isolations in the suspected cases. We need to understand and to track the contract and the line listing. We need to collect the sample referrals to NIV Pune. Dedicated isolation facilities need to be created, or if it is there already, that is to be used. The healthcare ward surveillance is very important, and the public advisor and the risk communications need to be announced immediately. So if we look at how the Nipah virus is actually staying within the environment, it stays in the fruit bat, and this is the Pteropa species. And most of the time, it actually causes the asymptomatic viral shedding. This is very important because the bats, they are normal. They are mostly the asymptomatic, like our hepatitis C infections, when the most of the people are asymptomatic for a long time. And this environmental contamination of the fruits and sap, and ultimately the human gets infected through this. Back to human, this transmission may happen. The contaminated fruits or the sap. Human to human from the body fluids and the droplets, nosocomial spread in healthcare settings. So these are the different way how the human can be infected by the Nipah virus from bat. So bat to fruits, fruits to human, human to human. So human exposure setting in the household caregiving, because before you understand it is the Nipah virus, before that the patient is getting a mild fever like the all viral fever that we have. The only thing that after a few days it's been progressively, very aggressively by that time, the the people within the family they get exposed with the Nipah viruses. So that we need to contact with the household caregiving. The healthcare work exposure is also important because many a times before understanding that it may be a Nipah, the healthcare worker may be exposed, and the unprotected contact with the secretions is very important during the care of the patients who infected with the Nipah viruses. So this is a very nutshell of pathogenesis, how it affects. The main thing is it gets into the respiratory or the oral entry that causes systemic viremia. Ultimately, the final insult to the body is the epithelial damage that causes the vasculitis. This is very important because the vasculitis is ultimately where the vessels get inflamed and it gets actually leaked out. And that causes a lot of issues and the neuroevasion by the blood-brain barrier that is also been breached. So these virus ultimately cause two things. One, that is the inflammations of the vessels that cause the damage to the organs and also that breach the blood-brain barrier, which ultimately affect the brain and the patients may ultimately landed up with the encephalitis. So there is a multi-organ failure cascade in Nipah virus as we see that because of the blood-brain barrier breach, the encephalitis and the cerebral edema that happens because of the edema and the vasculitis. The lungs, ultimately the patients will ended up with the ARDS and severe hypoxemia. For the heart, we can make it the myocarditis and the patients may go into a cardiogenic shock. Patient may develop AKI, metabolic crisis, and for the liver, the hepatic failure and coagulopathy. So, if we look at it, this patient is actually in a severe septic shock. There is no much difference of ultimate things, and ultimately, it is also been affected primarily of the vessels and which cause the vasculitis. So, for the neurological manifestations, Nipah virus, what we get is the acute viral encephalitis. The patient may present to us with the seizures and coma following a few days of fever and high mortality with the cerebral edema. So, basically, we need to understand for this group of patients what are the other viral infections that may cause the similar presentations and how can we differentiate that also need to be understood. Like the herpes simplex viruses and the others. So in the respiratory manifestation, patient may go into ARDS and we need very high profile ventilator setup and we need to go for a lung protective ventilation for all the patients who suffer from the Nipah virus induced ARDS. So in the other organ involvements, as I discussed earlier, this is the myocarditis shock, acute kidney injury, hepatic dysfunction and coagulopathy. So the clinical presentation is very important. The patient may present to us with a fever, headache, and myalgia, altered sensorium, and rapid progression within 24 to 72 hours. This is also very important in H1N1. Also, sometimes we may get the patients with a very severe respiratory distress, and the onset is very fast. So these are the areas we need to be very careful and very needful to understand that these group of patients need to pick up very early and need to separate at the emergency to make the quarantine and ultimately send all the samples for understanding what the virus is being infected. So laboratory diagnosis, how we diagnosed, we need to send for the RT-PCR from the throat swab, blood and CSF. We can do the serology and BSL-4 lab handling mandatory is very mandatory. This is the lab, where the lab is important that the BSL-4 we need to understand. So the differential diagnosis for any this sort of group patient, this is the herpes simplex, Japanese sepsis associated with encephalopathy and severe COVID-19. COVID-19 we are not getting it, but top of the three, these herpes, Japanese encephalitis and sepsis-induced encephalopathy, we need to differentiate from the Nipah virus-induced encephalitis. So this is the viral encephalitis the patient may present to us, but we need to understand how we can very early differentiate between Nipah and the Japanese and the HSV. So Japanese we really do not get very frequently, but HSV we get very frequently. So for the Nipah, if you look at it, the incubation is almost 5 to 14 and 2 to 12. So there is not much of difference. The key clinical clues that the Nipah virus that cause the encephalitis and ARDS both, whereas the HSV doesn't cause ARDS very frequently. The MRI pattern is very important. The MRI pattern, if we are able to do a urgent MRI of those group of patients, we might get the multifocal cortical plus brainstem involvement in Nipah. But in HSV, it's the medial part of the temporal lobe which is mostly infected, and this is very classical symptoms of HSV. And if we look at the CSF, that mild pleocytosis, but in HSV we might get the RBC and lymphocytosis. And case fatality is very important because in Nipah the case fatality is very high, is around 40 to 75%, whereas in HSV it is 10 to 20%. So this is the ICU management algorithm that we need to know. Is again, it is almost similar to a patient who was suffering from any virus-induced sepsis and the septic shock and encephalitis as well. So basically, it is the fever, encephalopathy, and the respiratory failure plus minus for any group of patients. We need to suspect the Nipah virus, send all the samples for immediate. We need to immediate isolate the patients and early ICU admissions. All the health worker has to be very self-protective, and we need to continue for the lung protective ventilation and the ARDS strategy if the patient is defined as that develop ARDS. Hemodynamic support, vasopressors, organ supports. These are all similar to the same thing because in Nipah, as of now, we really do not have any antivirus within ours because in HSV sometimes if we go for very early, we may have some antivirus which sometimes most of the time helps. But for the Nipah, it is very unfortunate that we really do not have any antivirus as of now in our hand. So this is the BSL-4 diagnostic lab where we have to maintain in the lab. We have to be very careful, and this is BSL-4. This is the guideline across the globe that is been particularly assigned for the Nipah virus, Ebola virus, Lassa virus, and variola, that is the smallpox. So they need to maintain certain facilities for their lab, entry, exit, and everything, and it has to be very strict. And from lab to the lab assistant and to from assistant to society cannot be possible. So this is the basic criteria and the difference between the BSL-4 and the ICU BSL-3. The only thing that you can see that the BSL-4 laboratory has to be standalone, and it cannot be been placed within a building. It has to be in isolated, especially in the very lone areas. But in ICU BSL-3, we can go for in ICU in any hospital setup. So in ICU BSL-3, we can go for the Nipah or suspected SARS-CoV-2, CCSF, everything. But for the BSL-4 lab, this has been designed specially for the Nipah, Ebola, Marburg, Lassa, variola. That laboratory setup has to be outside the hospital. So these are the basic other differences how we can differentiate between these two group of things, but we need to be very careful and need to understand that the BSL-4 lab has to have a very strict containment of the all airflow. So what are the options that we have for this group of patients? So there is no proven definite antiviral therapy as of now. Ribavirin, we have very limited evidence. Remdesivir, we have certain uses that has also been done in the state of Kerala, and monoclonal antibodies that are also under development. Because hopefully in future we should get some monoclonal antibodies which will be effective against this Nipah virus. So what is the role of remdesivir in Nipah virus infections, and what is the documentations or evidence that we have as of now? So this remdesivir basically is the adenosine nucleotide analog, and that inhibits the viral RNA-dependent RNA polymerase. And as we know that the preclinical evidence is very strong. The African green monkey model that was published way back in 2019 in NEJM, that is 100% survival when started even after the viremia onset. And the main implications of remdesivir, as it decreased the viral implications, it reduced down the CLS involvement, and obviously it improves the mortality. So when to consider this remdesivir for this group of patients when the patient is been established that suffering from the Nipah virus is the confirm of very high risk suspected in Nipah, early disease phase, and prior to the severe encephalitis with the institutional approval, and obviously we need to take the consultation of infectious disease specialty or the virology consultant. So as of now, the guideline positions, WHO CDC investigations, the NIB Pune, they have been positions this remdesivir for the Nipah virus is supportive and mostly protocol in. So those should be the day 1 in 200 milligrams and day 2 to 100 milligrams IVOD. We need to take care of liver enzymes. All of us have some exposure of remdesivir used during our COVID days. So in Nipah virus, if it is really been very highly suspected or is proved, if we can use the remdesivir, that must reduce the mortality and reduce the incidence of encephalitis as well. So if we look at the comparison between the remdesivir and other molecules for the Nipah virus infections, the efficacy wise, that reduce the remdesivir, it has also been established in the state of Kerala and Bangladesh as well. And other molecules like the molnupiravir and ribavirin is all are in a experimental segment. So what would be the outcome? The remdesivir twofold reductions of mortality, conclusive data and moderate evidence that stays with the remdesivir, not with other molecules. Clinical use, it has been used very extensively in Kerala and Bangladesh, and mode of actions, it inhibits the viral replication and non-structured proteins. So this is very important. As of now, the remdesivir, probably the other molecules will come in future with a better outcome. So what are the healthcare level precautions that we need to take when there is any suspected or the established case of Nipah virus along with us? There must be a dedicated isolation ICU. The strict PPE protocol should be maintained. The visitor has to be restricted, and we should look at the waste and decontaminations protocols. And this is the public health control and also the take-home message that early detections and the isolations are very critical. Healthcare worker protection saves the systems, and we need to be very careful. We have to be all aware about the suspected Nipah, and when the Nipah patients are still having a chance to present to us. And one health surveillance is very essential for all the suspected cases. So the early recognitions, rapid containment, and multidisciplinary critical care are pivotal in reducing mortality from the Nipah virus infections. Thank you. So I hope that will give you us a very nutshell informations about the Nipah, and once the Nipah, what are the options that we have and how can we contain the Nipah virus infections from patients to the healthcare workers and to the society as well. Thank you very much. So Priya, I think you have some questions you may ask now. Yeah, Priya, you are muted. Can you be unmuted yourself? I guess there is no questions or anything to discuss. So okay, I got some questions here in the meeting chat. Right. So for Shagor, that you have asked about what are the primary symptoms of Nipah virus, as I have discussed, it is almost like the other viral infections. The only thing, there is some features of encephalitis that actually precipitate very fast, and also the patients have some severe respiratory distress. So any viral infections which has been ultimately very, so the very presentations of the very severe headache and the presentations along with the respiratory disease, these are the symptoms that we should consider as a Nipah. But most important thing is that we need to understand the from where the patient comes, whether the patient comes from the cluster of the area where the Nipah virus is happening, or if there is any exposure with that suspected case or somewhere. So this is very important as well. So the travel history, whether the patients from whom the patient comes, and definitely the symptoms that I am discussing now. So does this happen to children? Yes, it may happen to children as well if there is any exposures. The precaution should be taken is important for all of us. If there is any, we need to understand it is the standard precautions for the society that anyone who is suffering from sneezing, coughing, or something that we need to maintain ourselves. We need to if we I need to go outside, I need to wear a mask, and also whenever I cough, we need to maintain the cough etiquette as well. But this is very important. If I've been exposed with that suspected, it has to be informed immediate to the health administrations. This is very important as a society, as a social responsible person. We should be informed immediately to the administration that I may have in Nipah, and I have as because I have been exposed in these certain areas where the Nipah is happening. This is very important. And as we know, the incubation is 2 to 14 days. So within 2 weeks of visited the area where the Nipah virus is happening, if I develop some sort of viral infections, I need to be careful. Right. So I am not seeing any other questions as of now. The another question there is that do infected person gets fever and fever persists? Yes, the fever may persist even in a fever. Uh, the most important thing is there is a headache also. So the headache, respiratory stress, and the persistent fever that is being suspected for the Nipah virus. So in hospitals, yes, we have actually taken one of the patient with suspected Nipah. Patient is still been admitted. We have checked for the Nipah, but the patient uh, is fortunately is Nipah negative, but he has all the symptoms because he has been not been allowed to get admitted in the other hospital. Then the patients go into the ID hospitals, and from the ID hospital to here. So ultimately we have treated him, but somehow the patient Nipah is negative. But ID hospital is one of the hospital who takes the patients who are suffering from the Nipah. And if there is any suspicions, you may also contact with us. It is the same as coronavirus that I have told you. The corona, in normally in the first, the corona doesn't involve the brain. So it primarily involves the lung. So in Nipah, you get involved the both the brain and the lung. In corona, you primarily involve the lung. Eating food is primarily that we need to know that what are the fruits is actually been very uh, preferable by the brats. So the foods that the brats eat, those are the fruits that we should not take. The one important thing, if any fruit is been damaged, we should not take that fruit. This is very important. So I guess there is no other questions, so we can conclude the session. So thank you very much for inviting me here in this platform with so much of learned people for discussing about the Nipah virus on behalf of Desun hospitals. So at the end, I would give a great thanks to all of you who will be present in these scenarios. I am seeing that there is a great attendance of 223 people over there. So I am happy and also been very thankful to all of you to give us a chance to discuss some medical issues with you. Hopefully in future we will able to do more with all of you so that it will be helpful for all of us. Thank you very much.